Hi everybody. Last week we talked about antihypertensive medications and medications that affected the cholesterol levels in our blood. This week we'll talk about medications that affect the hematological system as well as anticoagulants. Now, just to give you a little background, a little information, I'm sure you've heard before about the A&P of hematology. One of the most essential components of our blood are the red blood cells. Red blood cells are made up of several different molecules. One of these molecules is called a heme molecule, and it's a red pigment that connects to an iron atom. That iron atom then binds to oxygen. So there are four different heme groups, and each of these four groups attached to a globin molecule, hence the name hemoglobin. If we experience any decreased amounts of red blood cells, hemoglobin, or hematocrit, anemia can then occur. Anemias can be caused by a number of different problems. There could be a genetic disorder, which would cause sickle cell anemia, a pernicious anemia, which is characterized by a deficiency in vitamin B12. Vitamin B12 is needed for DNA synthesis. Causes of these vitamin B12 deficiencies can be improper diet or lack of intrinsic factor that's secreted in our stomach. Finally, there can be hemolytic anemias, which constitutes the destruction of red blood cells. This can be caused by toxins like snake venom, septic shock, or mechanical destruction. So let's move on to the next slide. And we'll talk about one of the ways where we can use a pharmacological application in order to correct deficiency of low red blood cells. Now, we would use ferrous sulfate to correct iron deficiency anemia. And it's estimated that about 4 to 8% of premenopausal women are affected by iron deficiency anemia. There can be other causes as well. Loss of blood from surgery, a diet lacking in meat or other iron-rich foods. We may not know that this anemia is affecting us. In mild forms of anemia tend to be asymptomatic. But as it worsens, as it progresses, a person may experience fatigue, pallor, or dizziness. In severe cases, heart failure could occur. So treatment is of the underlying cause. We give iron supplements like ferrous sulfate, and we do so in order to build up iron stores in the liver. It's important to note that it could take about 6 months to build up these iron stores. Ferrous sulfate should be taken on an empty stomach. Unfortunately, giving ferrous sulfate on an empty stomach can cause stomach upset. So there are a couple ways that we can bypass this stomach upset. We can give it with food that might decrease its absorption, but we find that certain foods, like foods high in vitamin C, can help to offset. And so we'll give ferrous sulfate with orange juice, veal, or fish. Now, it can also come in a liquid preparation. It can come in tablet form. It can come in liquid preparation form. These liquid preparation forms tend to stain the teeth. So, advising your client to use a straw or placing a spoon at the back of the mouth helps the iron liquid preparation to bypass the teeth, go directly to the back of the mouth, and avoid staining the teeth. It's also helpful to have the client rinse thoroughly after administration. Let your client know that the stools might be tarry and black and that this is a side effect. And also let them know that constipation could be a side effect. So we can help bypass that by increasing PO fluids, or in some cases, if that doesn't work, then a stool softener like Colace might be needed. Now, iron supplements can also be given intramuscularly, and that form of the medication would be called iron dextran. Given IM, we give the first dose, 25 milligrams, and then we check for a reaction. Unfortunately, when in this form, there is a higher potential for anaphylaxis. Understand that when given IM, this iron can stain the skin. So we have to give it Z-Track method in order to avoid staining. Now, one last point I want to make about administering iron supplements is that there can be the potential for iron toxicity. It tends to be higher with parenteral dosing rather than PO dosing. One of the reasons that children are sometimes poisoned is because they get a hold of vitamin capsules. So this is something important that we should consider. And iron toxicity tends to have certain signs and symptoms. Among these signs and symptoms, abdominal pain, vomiting, drowsiness, and irritability. If left untreated, it can lead to liver failure and scarring of the GI tract. When iron toxicity occurs, we give a chelating agent called Desferal. Desferal binds with the excess iron so that it can be secreted in the kidneys and eliminated from the body in urine. All right, so there you have the initial iron supplement we talk about, ferrous sulfate. We're going to move on to the next slide now. And we're going to talk about one way in which we can correct vitamin B12 deficiencies. Sometimes takes years to develop. There may be no symptoms at all. As it progresses, we might see weakness, sore tongue, numbness, and tingling of the extremities. As it worsens, jaundice may occur, and in severe cases, we find white matter of the brain can possibly degenerate. The nervous system spasms. Emotional disturbances can develop. So our goal is to provide daily requirements, replenish liver stores of vitamin B12. We can encourage the intake of foods high in vitamin B12 like dairy products, liver, fish, and seafood. We can avoid medications that might interfere with B12 absorption, and these would include the anti-gout medication, colchicine. They would also include potassium chloride and H2 receptor antagonists that are used for GERD or gastric ulcers. The dose is started off as 1,000 micrograms daily, given IM, and that's for a 4-day period, and then 100 micrograms every month. In the case of gastrectomy, this medication would have to be given for the rest of the client's life. And now we'll move on to the next slide and talk about ways to correct anemias that could be caused by chemotherapy, or by dialysis. And one of those ways is to administer a biologic response modifier. A biologic response modifier will change the body's response to diseases like cancer or the treatments like chemotherapy. Erythropoietin is a hormone secreted by the kidneys in response to lower levels of red blood cells. Epoetin alpha is a synthetic erythropoietin given subcutaneously, and it is indicated for clients on chemotherapy and dialysis. We must know for sure that the decreased amounts of red blood cells are due to the chemotherapy and not to a cancer itself. All right, so this is indicated for clients that are experience anemia secondary to a chemotherapy or dialysis, not of the cancer. Epoetin alpha will decrease symptoms of anemia. It speeds up red blood cell production and maturation. Clients that are given this medication need sufficient iron stores and a functioning bone marrow. Now, we have to take great pains that the dose should not exceed 1 gram for every 2 weeks. And we also have to monitor the hemoglobin. It is rarely used when the hemoglobin exceeds 12 grams per deciliter. The reason for that is that there is an increased likelihood of stroke. In addition, this medication is going to be contraindicated for clients with uncontrolled hypertension, since the increased hemoglobin can cause increased blood volume, which will raise the blood pressure. All right, so 2 essential points I want to make out is that we monitor the client's blood pressure, we monitor the client's hemoglobin. Now, suppose that the client is experiencing lowered levels of white blood cell, another important component of our blood. If our client is experiencing lowered levels of white blood cell, we could administer a growth factor that will stimulate growth of granulocytes. This medication, known as filgrastim, acts on progenitor cells in the bone marrow, and they will stimulate the growth of granulocytes, which are precursors to white blood cells. So essentially, the medication promotes the growth, differentiation, and the functioning of white blood cells. Ultimately, when we can do this and promote the growth, differentiation, and functioning of white blood cells, the medication decreases the duration of chemo-induced neutropenia, thereby reducing the incidence of infection, thereby decreasing or avoiding hospitalization. We'll now move on to the next slide and talk about some of the nursing implications associated with filgrastim. Filgrastim is contraindicated when there are myeloid blasts in the bone marrow. Myeloid blasts are tumor cells in the bone marrow. The growth of these tumor cells can actually be stimulated by filgrastim. So therein lies the reason why it's contraindicated. The most common side effect associated with filgrastim, bone pain, although the pain is usually relieved with Tylenol. Other adverse effects can be fever, muscle aches, and flushing. Unfortunately, treatment is expensive, anywhere from $1,800 to $2,800 per dose. The medication comes in single-dose vials. And when you're about to administer it, please contact the pharmacy to send it up 6 hours prior to administration. We must warm the medication to room temperature. All right, on to the next slide. We talked about medications that stimulate the growth of red blood cells, those that stimulate the growth of white blood cells. Let's move on to medications that stimulate the growth of platelets. So oprelvicin, or interleukin-11, stimulates platelet production in clients that are experiencing a platelet deficiency because of chemotherapy. Interleukin-11 stimulates megakaryocytes that eventually evolve into platelets, thereby increasing platelet count. Decreases the need for transfusions, and we know that there are several complications that can occur anytime that you transfuse. For clients that are on highly myelosuppressive regimens of chemo, there tends to be less effectiveness. Adverse effects of the medications: fluid retention, atrial fibrillation, and tachycardia. This medication comes in a single dose vial that needs to be reconstituted before administration. Okay, from here we'll move on to medications that affect the cardiovascular system, and I want you to take a quick look at this visualization of the progression of atherosclerosis. The medications that we will discuss soon help to prevent the harmful effects, the complications that can occur with atherosclerosis, such as obstruction or the development of deep vein thrombosis. So we'll move on to the very next slide. Talk a little bit about the extrinsic and intrinsic pathways. Start off by talking about the extrinsic pathway, which is caused by trauma to blood vessels from the outside, whether it's through cuts, bullet wounds. What happens is that thromboplastin is released, and that leads to the formation of coagulation factors, which eventually result in the production of an insoluble material called fibrin, and that is the basis of a clot. Now, once that clot forms, then a fibrinolytic system is started that will prevent the breakdown of the clot. Plasmin will bind to the clot to keep it localized and prevent it from traveling through the bloodstream and causing disruption in blood flow at a distant site. The intrinsic pathway is activated when collagen develops on the inside of blood vessels. So injury to the inside of blood vessels leads to a similar series of events, maybe using different coagulation factors, but ultimately resulting in the formation of a fibrin clot. So anticoagulants, that broad category of meds, will inhibit one or more clotting factors in the process and will prevent conversion of fibrinogen into fibrin. Anticoagulants are indicated for the prevention of thrombus or to inhibit the formation of thrombus. When we talk about anticoagulants, we are talking about some high-risk medication. The Joint Commission has made the safe use of these medications as one of their patient safety goals, and hospitals are expected to take steps to prevent injury from these meds. Complications from these medications have resulted in hospitalizations or in increasing the length of stay during a hospitalization. All right, so you always have another RN verifying. And a common one you're likely to see in the hospital, administered IV or subcutaneously, is heparin. Heparin is a chemical found in mast cells, and heparin inhibits thrombin formation. In other words, it'll prevent conversion of fibrinogen to fibrin. It's rapid, fairly predictable, but it does require careful monitoring and dosage adjustment. Now, the dosage adjustment is generated through monitoring activated partial thromboplastin time. So while on IV therapy, initially we could have lab draws every 4 hours, and we'll administer the dosage based on those results. Heparin would then be drawn and monitored daily. Heparin does not lyse current clots, only prevents the formation of new clots. It is indicated for clients that have had myocardial infarctions, extended bed rest, atrial fibrillation, where blood pools in the chambers of the heart. It's also indicated in certain orthopedic surgeries where blood can also pool. It can be given prophylactically to prevent myocardial infarction, cerebrovascular accidents, pulmonary emboli. Now, heparin works to prolong the APTT. The APTT measures the amount of time it takes to form a clot in the intrinsic pathways. Normally, it's about 25 to 39 seconds. However, we want to delay the formation of that clot. So we consider 1.5 to 2.5 times the normal range to be the therapeutic range. In other words, the usual clotting time is 25 to 39 seconds. We want to increase that by 1.5 to 2.5 the usual times. We consider that to be the therapeutic range. Critical range is 70 seconds. And whenever administering heparin, we always want to be certain that protamine sulfate is on hand. Protamine sulfate is the antidote. It will bind to heparin, inactivate it. It can work in as little time as 5 minutes. On to the next slide. I mentioned that heparin is a high alert medication. It comes in a variety of strengths. Please make sure that you are using the proper strength and the proper type of heparin. Heparin comes in a single dose vial to be administered subcutaneously, and that's for prevention of DVTs. Heparin also comes as a catheter lock flush product used to flush central lines and prevent the formation of clots in those lines. You do not use the catheter lock flush to administer subcutaneously. Have another RN verify the medication, the dose, and that it is not a catheter lock flush product. With heparin, there is always a risk of heparin-induced thrombocytopenia. Look at the pictures over here on the right. good depictions of what that heparin-induced thrombocytopenia might look like. We consider this to be an autoimmune process in response to heparin. Generally will start occurring 5 to 14 days after exposure. If this does occur, the client will have to be switched to an alternate product by the name of antianemics. And now we'll move on to the next slide. When clients are administered heparin, always assess for bleeding. One of the broad goals of heparin use is that we keep that therapeutic range of APTT 1.5 to 2.5 times the normal range, but also avoid hemorrhage. Always assess for bleeding. Look for hematuria, blood in the urine. Look for bleeding gums, blood in the stool, or blood-tinged vomiting. Use bleeding precautions. Use electric clippers rather than razors. Avoid trauma. Assess for overdose. Look at the APTT. Check for bleeding. Give protamine sulfate. Use with caution for clients that are at risk for hemorrhage. Those clients with severe hypertension, clients that have had an aneurysm, idiopathic thrombocytopenic purpura, hemophilia, or peptic ulcer disease. Clients might also be prescribed in place of heparin a low molecular weight heparin like Lovenox. Lovenox comes in pre-filled syringes of varying strengths. Do not mix Lovenox with any other medications. Never aspirate. Never massage after administering the medication. It prevents any trauma to the tissues. Now, an IV bolus might possibly be given for clients that are experiencing an ST segment elevation myocardial infarction and continue to receive subcutaneous Lovenox. It's used for prevention of DVTs and pulmonary emboli, used prophylactically for knee replacement surgeries or abdominal surgeries, which have a high potential for thrombus formation. It's also indicated for clients on extended bed rest, or mobile clients that are on bed rest because of acute illness. Lovenox does have a black box warning. It should not be given for clients receiving spinal anesthesia. There is always the possibility of spinal hematoma formation, and this hematoma could eventually cause paralysis. One further note, do not give Lovenox along with heparin. Severe bleeding reactions have occurred with concurrent use of the two medications. All right, so clients might receive heparin in the hospital, given IV or subcutaneously. They could possibly be discharged to the home on warfarin sodium, an oral anticoagulant. Now, warfarin takes about 24 hours to become active, so they could be administered heparin along with warfarin together for the first 24 hours, and then they'll be removed from the heparin and be given warfarin. Warfarin works a little differently. It acts on the extrinsic factors, and so we're going to be monitoring the prothrombin time. There can be a wide variation in lab values between different labs. We call the international normalized ratio, which takes into account that there are different reagents at use. An INR, an international normalized ratio, is developed through a formula where we take the client prothrombin time result and divide it by the average client result. For clients receiving warfarin sodium, we want that INR to be between 2 and 3. Well, much the same as activated partial thromboplastin time, we have a therapeutic value that we're shooting for when we're administering warfarin, and we want the therapeutic value of the prothrombin time to be 1.5 to 2.5 normal values. We also want, as I said, that INR to be between 2 and 3. Initially, we're going to monitor those levels daily, and then we're going to monitor those levels anytime a drug with an interaction potential is started. And warfarin does have a very high potential for drug interactions. Warfarin tends to be highly protein bound. Anytime we administer another medication, and the first one that comes to mind is aspirin, a medication like aspirin can remove the warfarin from proteins and cause an excess in free warfarin. And as a result, there's an increased anticoagulation effect because of the excess in free warfarin. So some of the medications with which we have to be very careful would be medications like aminoglycosides, selective serotonin reuptake inhibitors. I mentioned the aspirin before, salicylates like aspirin. Tagamet, the H2 receptor blocker used for treatment of ulcers, gastric ulcers. Antibiotics, antifungals, vitamin A, C, or E. Also, herbals like St. John's wort or ginkgo biloba can affect warfarin levels. Now, warfarin tends to have decreased effects when our vitamin K intake increases. Now, we can't avoid vitamin K entirely, so we have to eat consistent amounts of foods with vitamin K. Don't avoid the salad altogether. Just make sure that your intake is consistently of the same amount. A medication, very much like warfarin, is Pradaxa. I'm sure you've heard advertisements for this. Pradaxa binds to thrombin and prevents thrombus formation. Unlike warfarin, there is no antidote for Pradaxa. Pradaxa is excreted by the kidneys, so prior to administering Pradaxa, we must be sure that kidney function is intact. If kidney function is not intact, there is a potential for toxicity because the body can excrete excess amounts of Pradaxa. All right. In addition to anticoagulants, another medication used to ensure perfusion of peripheral blood vessels would be the oral antiplatelets, clopidogrel bisulfate or Plavix would be the most common. Now, usually platelets travel freely through the bloodstream. Anytime there's injury, platelets are going to accumulate at the site. They will then draw other platelets through the action of adenosine diphosphate. If we can provide a medication that blocks adenosine diphosphate receptors, we're going to change the plasma membrane so that this ADP can't bind to receptors. As a result, the site of injury cannot receive chemical signals that will start aggregation. All right, so these medications work at the site of the blood vessel injury, and they begin to work even before clotting cascade is activated. The indications for Plavix use would be to reduce atherosclerotic events, prevent MI, and prevent stroke. You might also see them for prevention of stroke from cardiac surgeries like stent replacement. The adverse effect is going to be the risk of bleeding. So be careful and always assess for bleeding. Avoid use of over-the-counter NSAIDs. Use caution with proton pump inhibitors like omeprazole. Omeprazole has a tendency to block the metabolic pathway and decrease the ability to prevent clotting, so that there is an increased risk of myocardial infarction when giving along with omeprazole. Another medication that inhibits platelet aggregation, and you don't see this as much anymore because of some of the side effects, but you might possibly see a client that's still taking Ticlid. It inhibits platelet aggregation, prevents recurrence of stroke, but a small percent of clients actually develop neutropenia, agranulocytosis, so we tend to see Plavix more often. When on Ticlid, the client should have their CBCs measured every 2 weeks times 3 months to make sure that white blood cell count isn't being affected by this medication. Side effects: GI distress, purpura, that itchiness known as pruritus, and dizziness. There is a potential here for multiple drug interactions, increased bleeding anytime it's given with anticoagulants, selective serotonin reuptake inhibitors, and H2 blockers like cimetidine. Ticlid, in addition, will decrease digoxin levels. Aspirin also helps to prevent myocardial infarction and cerebrovascular accidents. It decreases platelet aggregation. It does increase the risk for bleeding with heparin and warfarin. It's not benign. Even though it's over the counter and widely used, there's always a potential for metabolic acidosis. Aspirin is acidic in content, so we do have to be careful and assess for that. In high doses, it can cause tinnitus, ringing in the ears, a CNS stimulation, or Reye's syndrome in children, as can any NSAIDs. Now, aspirin works on the cyclooxygenase pathway that helps platelets to function. The aspirin inhibits this chemical by binding to it and irreversibly prevents its function. So aspirin essentially will remain in our system for the life of the platelet. One last category of med I'd like to talk about is the tissue plasminogen activator. We tend to see these medications not so widely used anymore, but they are given when we know for certain that the client has experienced a cerebrovascular accident. It's an enzyme that's used within the first 3 to 4.5 hours after an ischemic CVA, so there's a very short window of administration. This medication will bind to fibrin and convert plasminogen into plasmin. The plasmin will then break down the clotting factor, and the clot will then disintegrate. So unlike the other medications, this actually does break down the clot. The other medications that we discussed prevent the clot formation. Redoplase has been found to dissolve clots in coronary arteries. Unfortunately, there is a potential for internal bleeding that can affect the gastrointestinal, genitourinary, intracranial, or retroperitoneal areas. There's also an increased risk for bleeding with NSAIDs, some antimicrobials or anticoagulants, so assess for use of those medications. We would not give this in a history of a recent CVA, any active internal bleeding, because it would make the bleeding even worse. Aneurysms. Okay, the nursing implications associated is that when this is administered through a line, flush the line well before and after. You're going to monitor for bleeding and arrhythmias ongoingly. Don't give the client IMs that can bleed, and keep the client on bed rest. Thank you, everybody.